Good morning, everyone. A very warm welcome to the unprecedented National Institute of Health, National Institute of Dental and Craniofacial Research Forum, proudly hosted by A.T. Still University. To begin, I would like to take this opportunity to thank our University Chancellor, Dr. Craig Phelps. Dr. Phelps, please stand. Thank you. Dr. Phelps, we would like to thank you for your support of this event and for your ongoing support of research across all of A.T. Still University. Thanks to you. There are many additional university leaders I would also like to acknowledge, so please raise your hands when you're called upon, including Interim President Gayla Sublette of our Missouri region, all Chancellor's Cabinet members present, including Dr. Kim Perry, my fellow deans, including Dr. Robert Tromley of Arizona School of Dentistry and Oral Health, Dr. Marissa Hasty of College of Graduate Health Studies, members of the A.T. Still Research Institute, Dr. Ann Splarich, Dr. Hannah Namar, and Dr. Brian Degenhardt, all involved in the forum's planning committee, and of course, members of the Missouri School of Dentistry and Oral Health leadership team, Dr. Poonam Jain, Dr. Amar Musawi, Dr. Gashandra Branchmays, and Dr. Kristen Marquez. There's also a special guest who registered online that we would like to acknowledge at this time. Ms. Vicki Wilbers, Executive Director from Missouri Dental Association. Ms. Wilbers, are you online with us? And can you say hello, please? Okay, all righty. So we welcome Ms. Vicki Wilbers. Thank you all, one and all, for being here today. I'm thrilled to see so many of our faculty and researchers in person and virtually as well. As many of you know, I'm Dwight McLeod, Dean since 2016 of A.T. Still University, Missouri School of Dentistry and Oral Health. Our dental school is so pleased to host this event at our ATSU Most of St. Louis Dental Center locale. Today, we gather to enter meaningful and action-oriented conversation with our guest of honor, Dr. Webster Syriac, to gain a better understanding of how NIH and IDCR views, engages with, and supports research at universities like A.T. Still University. ATSU seeks to advance its scholarly research output and further develop its research initiatives, particularly in service to vulnerable patient populations. Whether you're an expert or an experienced or novice researcher, today's agenda has something special for everyone. The planning team led by the A.T. Still Research Institute has assembled a wonderful lineup of speakers and built-in opportunities for open dialogue, networking, and collaboration. Before we start, I have a few housekeeping items to announce for our in-person guests. Food and beverages are available along the back wall, so please help yourself. There's one restroom on this level and additional restrooms are available downstairs via the stairs or elevators, so just follow the signs. At this time, I would like to introduce our guest of honor and keynote speaker, Dr. Jennifer Webster Syriac, who serves as the acting director of the National Institute of Dental and Craniofacial Research within the National Institute of Health. An accomplished clinician, researcher, and leader, Dr. Webster Syriac previously served on the faculty of the University of North Carolina School of Dentistry and the University of North Carolina School of Medicine for more than 2 decades. Dr. Webster Syriac earned her PhD in microbiology and immunology from the University of North Carolina, Chapel Hill in 1998, her DDS from the State University of New York, Buffalo in 1992 and her BA in Biology and Interdisciplinary Social Science from SUNY Buffalo in 1988. Please join me in giving Dr. Webster Sirik a warm welcome from our entire university community.
All right. So let us proceed. I thought I'd begin by sharing the breadth of the problem. Okay. And as you know, not sure if you do know, but if we look across this world at how big the problem is in terms of oral diseases, when we compare oral diseases to other non-communicable diseases, this is the biggest. This is the largest collective number of cases globally of non-communicable diseases within the realm of oral disease. It's much higher than mental disorders, than cardiovascular disorders, the cancers, the diabetes all around the world. This is a big problem, and these diseases are largely preventable. And I am sure that consistent with the mission of AT Still is to help remedy this challenge and this problem. Again, it's a global problem. If we look at the most prevalent conditions of all conditions across the entire world, is untreated dental caries and permanent teeth. That is the most prevalent disease in the world. Okay. Severe periodontitis is the sixth most prevalent, but as we look at more common periodontitis, we know that here in the US, it's at least 47% of adults. And so periodontitis is huge. We look at cancers of the lip and oral cavity. These remain among the top 15 most common. And 158 million people are plagued with complete tooth loss. Why is this a problem? It affects a person at every intersection of their life. Their ability to communicate, their ability to have appropriate nutrition in terms of being able to chew those healthy cruciferous vegetables, and their self-esteem. Cleft lip and cleft palate remain a major challenge at 1 in 700 live births. Anoma, something we don't often see here in the US, more often in sub-Saharan Africa, is a necrotizing disease that starts in the oral cavity and is treatable early on. But unfortunately, many of the folks don't come in early on, and then we end up with a 90% mortality. Okay. And then HPV-related oral pharyngeal cancers. 70% or more of oral pharyngeal cancers here in the US are associated with HPV. There is a vaccine. This is preventable. There's a lot of work to be done. And we knew in the year 2000, when David Satcher, the then Surgeon General, put out the first report of oral health in America, that there were many challenges, and he pointed out many disparities. When we go into 2021 and looked at oral health in America, advances and challenges, we see that oral health has improved for some, but not for everyone. The needs of those who are underserved and underrepresented still remain unmet. And I know that this is a clear edict for AT Still, and I appreciate and applaud what you're doing. But there's research that can be done to help us do it even better. You know, again, our oral health in the US has improved for some, but still, half of the children in the US between ages 6 and 8 have caries. Okay. We know that 92% of working age adults in the US have had dental caries, 92%. Okay. And again, we know that in those individuals who are underrepresented minorities, we have high levels of untreated decay. And the cost to our society, huge. $245 billion is the estimated global economic burden. That's a lot of money for something that's preventable. Of course, this cost is not just direct treatment costs, but also productivity losses because people were unable to give their best or do their job because of their oral malady. And we know what's happening. We know that there's a clear dose effect relationship between sugar and decay. And we know that there are microbes that help drive it. But we have not or have not been able to exercise and get to prevention in the US. Okay. And the costs are very high, not just at the individual level, but also at the societal level. At the individual level, we know that untreated decay and unaddressed oral disease can result in systemic health problems, right? A person has bacteremia. This can result in heart complications with subbacterial endocarditis. This can result in worsened diabetic outcomes. This can result in death. If you can move to a brain abscess, that's what happened to Diamante Driver, right? We know that again, when you have painful teeth or pain in your oral cavity, sometimes it's difficult to ingest the appropriate nutrition, okay? And that's not good for the rest of us. We know that with pain, it's difficult to concentrate. We have decreased academic achievement. And finally, because many of these services are not covered, okay, and many people do not have insurance, there is increased financial stress as people have to make decisions. Are they going to pay their light bill or are they going to get this tooth addressed, for example? What about the societal level? We know that, again, people cannot be productive when they're in pain. So we have reduced workforce productivity. We have increased healthcare costs because people get, many people don't have access to care. And that's something you're working hard at remedying through your programs at AT Still. But right now, we're having serious increased healthcare costs because of emergency room use, but also people waiting late, you know, or having unaddressed oral health care needs can result in fevers of unknown origin for those who are hospitalized, increased rates of pneumonias and people who are in the intensive care unit. The costs are tremendous to the healthcare system and to our country because still to this day, dentistry is among the top 3 reasons why we have difficulty enrolling our military. Okay, it's mental, dental, and obesity. Okay. And in fact, military readiness is the reason why NIDCR was formed. We were the 3rd institute to be formed in 1948. And the challenge was in World War II that Truman was unable and his military were unable to enroll people because of so much dental disease and decay. Okay. And this remains a significant challenge. We've made some strides, but there's a lot of work left to do, and we look forward to engaging you in this work as well. Okay, you, every student, every practitioner, every teacher, we need you, okay? And we know that what you get in terms of learning about research can provide many, many parallel pathways. Okay, you can impact academia. It can help with public health, which is a major challenge that we're trying to address. Can help with science policy, science communication, industry, advocacy, government, like I'm doing. It can make you a better practitioner in terms of dentistry. Okay, so what we have in place are multiple opportunities for training. And what you can see is that these training opportunities go from preschool all the way out to investigators, and not just junior investigators, okay? And we have programs that occur on the NIH campus. And so you can come to the NIH campus and be involved with the summer internship program, for example, for college students or dental students, or the medical research scholars programs also open to dental students. But as you move forward in your career, there are fellowships that can be done and sabbaticals, research development. In the extramural community, okay, and at your university, there are funding that NIDCR can provide to help with science education partnership programs. I happen to know that you all have wonderful programs of outreach to very young people who will become future scientists, future dentists, future medical people, future healthcare workers. These programs could be funded by science education partnership programs, for example, for the Dreamers or the Dreamline. Okay. There's funding for summer research experiences that can occur at AT Still that can be targeted from, you know, early education on out to dental students, okay? And institutional training grants that can also be applied for, as well as direct training grants to students. There's a mentoring network between NIDCR that's and AADOCR, okay? And for anyone who's involved and needs help with loan repayment, they can apply for loan repayment programs, okay? There are career development awards that occur at every level, okay? Mid-career or senior people who maybe have left science or want to now enter the field coming from something else, there are re-entry awards that are available. There are mid-career awards that are available, and then there are lots of awards that are available at earlier stages. What about programs specifically to enhance diversity? And you can see there are many programs across after this, I'll share a QR code that you can use so that you can directly access this information. Okay. But these are open to anyone, including to any institution, including AT Still. And what you have here on the bottom are NIH programs, but on the top are programs that are specifically also funded by NIDCR. And these are supplements to help with the transition for dental scientists. We have a KO1 program, a Career Development Award to enhance diversity, also to promote reentry, and the mentoring network, as I mentioned earlier on. So there's lots of opportunities and different mechanisms that are available at NIDCR. For those of you who are just finishing, perhaps just finishing up dental school, and would like to have experience as a clinician or clinician scientist, this is a customized career development program and research experience for people who are dentists. They can come to NIH and become fellows. They have experience, get the latest clinical and translational research methodologies. And basically, you spend about 1 day a week clinic, and the rest of the time is really effort devoted to research. Okay. These applications are due the 15th of September, so coming up soon, of every year. And the program starts July of every year. And there have been a great number of successful individuals who've gone out to become faculty members. And if you have more any questions around this, please reach out to me or go to this website. We also have a dental public health residency and fellowship. And this is a 3-year program where the first year is focused on certification for the Dental Public Health Board. And the unique thing about the program is the second 2 years are in postdoctoral collaborative research. And here we're able to really leverage the resources that are on our campus and across different federal agencies and local institutions so that people can get the opportunities to really become thought leaders and focus in on specific areas of dental public health research where they have the bandwidth to now not only do the research, but help lead the field, okay? And there are stipends available for qualified applicants, and we would love to have folks apply for this program. We also have thought a lot about what needs to happen next, okay? If everybody in the US right now who needed dental care tried to get it, couldn't happen. We do not have the bandwidth across the field. There aren't enough of us. There aren't enough dentists. There are not enough dental scientists. And so we put together last summer an external workforce to re-envision the oral health research workforce pathway. And it was determined that our focus really has to be early, has to be on those elementary school children, has to be in that K through 12 pathway. And you'll see that among our stakeholders were the American Dental Association, American Dental Educators Association, the AADOCR, the American Academy of Pediatric Dentistry, the Hispanic Dental Association, the Society of American Indian Dentists, the National Dental Association, and NIDCR. And you'll see that Dr. Perry from your institute was there and provided significant contributions to this ongoing effort. So that was the kickoff. We continue to meet over the year. There will be SEPA grants that have come out of that, and there will be a speaker series actually this fall. And I hope that you all will get involved with that speaker series, and we will certainly let you know as we begin to get going with that. We also put together an important tool, again, targeted to young people, middle school, high school, even undergrads. And so this QR code will bring you to a site focused on the world of opportunity in dental research. And here there's an article, there's an activity sheet for kids, there's a PowerPoint and lesson plans for teachers. And there's a podcast with PowerPoint and transcription, and also even cartoons or animations with the associated script available. So please take advantage of this resource as you reach out to individuals who may have an interest, and to your patients who could become your colleagues in the future. Again, here is a QR code for the Research and Training and Career branch. If you're interested in all of the different programs that I shared that could occur at AT Still, Anissa Brown is our Chief Extramural Research Training Officer, and she's your contact. If there's an interest in coming to NIH and getting involved there, Dr. Belinda Hauser is the training director in our intramural office. So please feel free to connect with us. You can also reach us on Twitter, LinkedIn, and through other mechanisms. But please reach out, because there's lots of opportunity, and this is the place where it's the one-stop shop to see where those opportunities exist for you. I'm just going to share with you my own journey just really briefly. I was always very interested in what causes diseases and how and why they come to be. And I also like the opportunity to work with other people, like-minded others who just wanted to know the answer. And so that we could work together to make a difference for others. And we put together over the years a program that we call VOICE, Viral Oral Infections and Immune Suppression in Cancer, with our goal being to understand viral and molecular pathogenesis in states of health and immune compromise. And we've had opportunities to do work in clinical trials and basic mechanistic studies on HIV and other tumor viruses, and to do some work in translation and also salivary diagnostics. But the key here is, I'm going to just share with you briefly what my journey is, but how I was able to use those mechanisms myself. So I did I'm from New York, where the little circle is here. I did my undergraduate in upstate New York, as you heard earlier. And while a dental student, okay, had the opportunity, actually, as an undergrad, had the opportunity to be, uh, shadow a dentist, Dr. Elaine Magna in Buffalo. And she hired me to become a dental assistant. And as an undergraduate, I did undergraduate STEM research at University of Buffalo. And when I got to dental school, I became very interested in oral pathology and oral medicine. But right now, if we look at those books, if we don't read the books now, we look on the websites, what have you. But the key here is there are still so many things that say idiopathic or etiology unknown, okay? And how are we ever going to fix it if we don't really understand what's causing the problem, okay? So I became interested in research and actually did summer research at the University of Rochester in a program that was actually being led by Dr. Lawrence Tabak. So I did that a couple of summers, and then at the end decided to put together my interest in dentistry with this question that I had around what developed these diseases, and research would be a tool for me, a tool to actually understand what's happening. So after doing research at University of Rochester, I then applied for the dental scientist program that was held at UNC Chapel Hill. It was one of about 8 places in the country, and this is my PhD mentor. After that, I did a general practice residency and a postdoc in infectious diseases with Mike Cohen, and then realized very quickly that while I had good clinical training and really good bench training, I did not know how to put it together. And the light bulb moment was for me when I went to talk to a statistician, and it seemed like that guy was speaking a different language. So I needed to go back a little more training, and I did this clinical research fellow program, where I then received what I needed to be able to do clinical trials. Then went on to become a faculty member, and had really awesome opportunities in research to meet people from all around the world, but also to get involved with Malawi, who when I on my first visit they had about 14 dentists in their country. And we had a program, like I'm sure you do, that interfaces with other places that are under-resourced and sent our students there. And I would go with them, but also had the opportunity to meet with their Ministry of Health and work with them towards developing their own school. And in fact, the first school for Malawi began in 2019, and their first class graduated last year. And I'm very excited about that. And so after a couple decades at UNC, I then joined NIDCR as deputy director and have had the opportunity to really impact science and dentistry and the problems that we have more than one patient or experiment at a time. So here's my pathway, okay? While I was in high school, I did some pathway programs in Long Island. When I first went to Buffalo, I was in a minority academic achievement program, and had an opportunity to go to the University of Maryland at an intercession program to become familiar with what it was like to be a dental student. And then when I shared with you as a dental student, I had an opportunity to become involved in a T32 program. That's a training grant program for minority dental summer student research. After that, I went on to do a K program, an institutional program at UNC for the Dental Scientist Award. I did a postdoc as a part of a T32, again, a training grant in infectious disease, and then did 2 career development awards. One was this where I did the fellowship to get that clinical research background, but then I received a K23, which was a patient-oriented research award, career development award. So, and then I moved on to independence and was able to get be a mentor for other people So I was a mentor for K Awards, for F Awards, and also for diversity supplements. And then also served as a PI for several training grants. There were also T grants. One was for the pathogenesis of viral disease, and one was for mechanisms of translation from other institutes, and then served as a faculty member in many other T grants, okay? And then for my own research, for our own basic studies, we had R grants, and for our clinical studies, we had U grants. And so just sharing that I was able to utilize the full NIH pathway throughout my own development, and it's clearly an opportunity for each one of you as well. And that led to a pretty rewarding and privileged career for me over the years, where I've had some lessons learned. And for the students, I learned to be a scientist. I never thought I would be a scientist, okay? But what I've learned is being a scientist is really just being a person who really wants to know the answer, okay? And has the wherewithal to work with other people and understand the methods in order to ask the question, okay? I've learned that it is very important to let the patient and the data guide the studies that you're going to ask, okay? And also that you can't move forward without being a lifelong learner. So you got to learn new things. And science is a team sport. It requires collaboration in order to answer most questions. And finally, and really importantly, not to let other people set limits for you. Okay. I understand that you shared that you're not a research intensive institution at AT Still. But you can be, because you bring something. I mean, or you may not aspire to be, but what you bring and what you have have something very unique in terms of the patient populations that you have, the students that have a heart for service. So as we move towards oral health for all, there are many opportunities for you, AT Still, okay, to move in this direction and incorporate research. Okay, so let me share with you a bit around what NIH is doing to turn discoveries into health. And there may be discoveries that you can make in your unique populations that can help inform what's happening across the globe. Okay. Excuse me for a second. So again, at the NIH, NIDCR is one of 27 institutes and centers there. Okay, and we were the third one to be founded. And we are the funding that we're doing is across the entire US. And the entire US, with the fewest grants being one grant, that's to the US Virgin Islands, and actually the most in California. But every state has been the recipient of some NIDCR funding, and NIDCR funds science all around the world. You can actually see here. These orange dots are places where NIDCR has funded science. We're really focused on advancing knowledge around dental, oral, and craniofacial health and disease. And the key is we've got to translate those findings into prevention, into early detection, into treatment strategies, because that's what it's going to take for us to improve overall health for all individuals and communities across the lifespan. We're actually the largest funder of oral health research in the world, and we fund the research that actually informs practices of more than 200,000 dental healthcare providers here in the US. We provide about 63% of NIH funding to dental schools. And when we look at what we've done over the year, over the years, I've had an opportunity to just take a look back and look at the grants, and across all of the grants that we've funded over the years, and what has that resulted in. And what we can see is that there are more than 175 products across multiple healthcare fields. And if you look across these names, I'm sure that you will recognize some of them. But importantly, we can look across the fields of medicine. Almost 30 products that are important to dermatology, 38 in cancer, and these hit multiple different types of cancer. 12 in infectious disease, 24 in pain, 29 in psychiatry, in neurology, excretory and GI, and inflammation. So our mark is pretty significant in terms of products and movement of this foundational science, even beyond dentistry. So we have an NIH director, Dr. Monica Bertagnoli, who's been there for about a year, and she shares, and I concur, that our job is not done. It is not done when we make a scientific discovery. The job is done when people are living long and healthy lives and have good quality of life, okay? And that's something that we can make a difference to in terms of oral health, you and I. So let me just share with you some of the NIH-wide initiatives that are ongoing. And what we know here is the health of the US is declining. Okay, it is declining, and it's worse among those who are underserved and underrepresented. That's where the steepest decline is. Okay, what we need to do is work towards improving health outcomes and research equity by leveraging primary care settings like the ones that you engage in at AT Still, integrating research into those primary care settings. What will this do? This helps to facilitate and accelerate research advances for adoption and implementation in everyday clinical care. This is something that AT Still can help with. This will allow improvement of health outcomes and advancing health equity for all Americans. Okay, so this is a relatively new initiative, and the approach will be to expand enrollment in existing studies and pilot new ones, work with existing research networks that identify new collaborations, and then to partner with primary care partners and community partners, which you have done very well at AT Still. And then, of course, pursue innovative study designs. So this is a common fund program that just came out this year with the goals, again, to establish primary care focused clinical research network that is disease agnostic, but will include dentistry, okay? Will include oral health. And this will facilitate clinical research in mission areas across all of the ICs, including NIDCR. This is going to integrate innovative research into routine clinical care in real-world settings, something I think that you are primed to do, and to also create a foundation for sustained engagement with communities that are currently underrepresented in clinical research. And this is like the communities that you all are serving at AT Still, okay? So they're working on a quick launch this summer at a few sites just to get proof of concept, and then the plan is to expand in 2025 and beyond. Okay, there's also the National Strategy for Women's Health, and a presidential memo was signed last November, and things are moving forward with this, recognizing that women make up half of the US, but actually the research and data on women's health is really lagging. And it's a significant area of opportunity for women's oral health as well. And we need to be working towards a national strategy for oral health, okay? And we're working on laying the groundwork for that now. There's also the All of Us research program, which is focused on people. You know, oftentimes in the healthcare system, we have patients, but these folks are self-identified because something's wrong. Okay? The idea here is to really bring in 1 million people who represent all of us. Okay, the diversity across the US, and to capture all of that. So where are we right now? We've got close to 500,000 research surveys. They've got electronic health records, physical measurements, biospecimens. We're working to make sure there are merged medical dental electronic health records to make sure dental is well represented here. There's also data related to mobile and wearable tech, a bunch of different assays and omics type studies. And in fact, they've now looked at whole genome sequence data sets that have shown that there's variation at more than 1 billion locations, which is exactly or close to a third of the human genome. So while there's a lot of things that make us similar, there's also a lot of things that make us unique as individuals. And there's lots of publication and information coming out from all of us and really showing how critical diversity is, right? The research programs are opportunity to enhance diversity of biomedical research. We can see that frequency of pathogenic variations and ancestry-driven disparities, okay? So there's a lot of work coming out of all of us. They're still enrolling. It's a significant opportunity. Here's the QR code for the press release if you'd like to take a look. But it's also an opportunity for AT Still. If you would like to help with enrollment related to all of us and get involved with that program, or to actually do secondary data analysis related to it. Our President Biden has reignited the moonshot goal a few months back, recognizing that there's the opportunity, if we work together, to cut the death rate from cancers by 50% over the next 25 years. And it really is going to take all of us because, as you know, we've got a lot of work to do with oral cancer. What we know is if you look across those cancers that have been screened, like lung, colorectal, breast, cervical cancer screening, where you see the screening, look at the numbers of cancer-specific deaths that have been averted, okay? Where is that not happening? Oral health. Why? We don't have good screening tools. We don't have good biomarkers, and that's something that we need to work towards for oral health. And I will share with you a program that we have in place right now to help us move there. Opioid abuse remains a significant problem, and the Helping to End Addiction Long-Term Initiative, or HEAL, is in place to help us move past this, to help find scientific solutions to the opioid problem that we have. And if we look at overdose drugs, we can see that, and we all know that dentists are prescribers or high levels of prescribers of opioids. Dentists are getting much better with that. The challenge is also emergency room use where there isn't a dentist. And when we think about who's getting pain meds and antibiotics, that's happening at the highest rate for those who come in for dental problems. Here, what we can see is the problem with synthetic opioids and fentanyl, because when people try things, okay, people try cocaine or meth or heroin, oftentimes on the first try, they don't die. But with synthetic opioids and fentanyl, that is the case. And the number of overdose deaths continue to climb while it has begun to plateau in some populations. In other populations, it continues to go up. So there's a lot of work to do. There's been some progress with HEAL. There was the first in-human clinical trial of an antibody that can prevent fentanyl overdose. That's great. There's been a phase 1 clinical trial of non-narcotic small molecule analgesics so that we don't have to give opioids for pain, but this is another option for acute and chronic pain. There's been some progress towards real-time measurement of chronic pain signatures. And we also know that buprenorphine is a safe and effective treatment for people who happen to use fentanyl. Unfortunately, there are significant dental consequences to it. Again, HEAL research is informing work by SAMHSA to actually determine the needs for naloxone, and that's being much more widely distributed now. And then there are new programs. One is a Native program focused on Native communities, and also one focused in rural populations that was launched in 2023. Data is also critical. It is a very important resource. And we could even view data as the new oil, right? And when we talk about data, we mean data across the masses, across the populations, down to the molecules. Okay. And we've got to really agree that we need to maximize the value of data. Why? Because it's really going to be how we move towards breakthroughs and discoveries. But we really have to have good policies and resources and infrastructure to make sure that the data is being shared responsibly and reused responsibly. And in reuse, we mean making sure data are available for people to continue to ask other questions of the data, secondary data analysis. And so NIH is working hard to promote effective data sharing as a rule and not the exception. And in fact, we need to make sure that new data analytics are applied to data that includes everyone, okay? And when new discoveries are rapidly and equitably adopted into clinical care, new data can help us move that forward. So we are committed to harnessing the power of artificial intelligence and machine learning, but it has to occur across diverse fields, diverse diseases, diverse scientific communities, diverse people. Okay. But there are some challenges, right? We've got to make sure that we have good clinical and healthcare data that's carefully annotated, that's representative of the full diversity of the American people. You have a head start on that at AT still. We don't have the data that we need in terms of lived experiences and their cultural and historical context, like social determinants of health. Got to be more intentional about making sure that's collected. There's a need for validated, ethical, and trustworthy artificial intelligence algorithms in healthcare. And we also have to ensure that we've got diversity within our workforce and making sure that we've got the technologies across all populations and not just some. So those are some of the challenges. But NIH is working to build a bridge to artificial intelligence through making sure that the data are diverse, fair, and AI ready, to making sure that the ethics are accurate, reliable, and the data is actually being ethically sourced, and that we think about people and that the teams are diverse, that the research cohorts are diverse, like those that you have at AT still, and that everybody's getting the training that they need so that we can move towards personalized dentistry, that we can move towards functional genomics in the context of oral health, that we can utilize artificial intelligence and machine learning at the chair side in the dental office. And then we could move towards precision oral health. Okay. So just quickly, those are some things that are ongoing at NIH. I'll give a quick update on the budget and then share with you what we're doing at NIDCR and things that things that AT still can get involved with. So the president's FY25 budget request is for $521 million. And this is a $1.5 million increase. Our budget was flat this past year, which given inflation means that we basically got a decrease. And this includes support for foundational research, translational research, clinical research, workforce development, intramural research, and research management and support. Okay. And so when we look at who's funding dental schools, we can see that the majority of funding for dental schools as of past year it comes from NIDCR, and then dental schools also do receive NIH funding from other institutes as well. When we look at how the money is spent, okay, 85% of the budget goes outside, okay? With a focus, we have 65% to grants and 14% to the management of those grants, 15% to science that happens at NIDCR, and 6% to keep the lights on. And that's how we've been doing it you can see here's data from the past 10 years, but this is our formula at NIDCR, okay? And here you can see what our appropriations were from NIH, from our congressional appropriations. And you can see here that again, our budget was flat 23 and 24. And what you can see here are our actual dollars in the hatched bars. And the actual dollars, once we adjust for inflation, you can see that we've had a slow decrease down, but we're continuing to get the work done. If we look at our success rates remain in the 20%, and we're really at now still at 22%, among the best success rates across the different institutes. And our success rates for early stage investigators is quite high. And we're really intentional about what we can do to support early stage investigators. And that's an effort that's not just happening at NIDCR, but across NIH, because we recognize that our early stage investigators are our future. Okay. So what have we been doing? Okay, I'm going to just share with you some of the research that has gone on, and then some of the signature initiatives that are in place. Now, we know oral health is whole health. It is the place, it is the portal to pathogens. It is also the portal to all of the risk factors. Beyond pathogens, it's where we eat, it's our nutrition, it's where we smoke, it's where we ingest substances that may not be good for us, right? It is the major portal for how we interact with the environment. But it holds the promise of a place where we can actually monitor how someone is doing, how they're healing, how they're complying with their medications. We have the potential for oral diagnostics, like salivary COVID tests, for example. There are very few examples of a systemic disease that doesn't have an oral manifestation. And it's a real opportunity to quickly take a look when someone says to see how they are doing. Again, intake of common risk factors, but a very critical determinant of overall health in terms of how you're doing in terms of your mouth and your oral health is a critical determinant of your overall health, your overall well-being, but also about you, right? About your own identity. It's how we interface with the world. It's our image, right? And we also have to bear in mind that the other determinants of health are critical for oral health outcomes. Those include environmental, social, behavioral, gender, and commercial. So we've made some significant investments over the years in regrowing tissues and function, you know, and that's important. So we're really working towards strategies to regrow and restore function to dental, oral, and craniofacial tissues, including gums, bones, skin, nerves, and glands, and making sure that these tissues are vascularized, that they're innervated, that they can work. And this is occurring in the context of the DOC-TRC program, or the Dental, Oral, and Craniofacial Tissue Regeneration Consortium. We are working towards really facing cancer head on. As I shared, 38 cancer drugs have been developed based off of NIDCR-funded research. And scientists are working to untangle relationships between tumors and cancer-promoting neuron environments within the microenvironment, looking at checkpoint inhibitors and cancer vaccines, and new portable imaging systems, as well as biomarker research to really capture head and neck research early on. We're working on salivary gland dysfunction. This is a major challenge for us. And there's a gene therapy trial that's actually going to be published this year. We've made some significant progress towards generating salivary glands from stem cells that promote budding. And we're working on testing the safety and efficacy of an FDA-approved rheumatoid arthritis drug for people who have Sjogren's. Okay. When we look at pain research, the first multidisciplinary pain clinic was an NIDCR clinic. okay? And the first NIH multidisciplinary effort was NIDCR promoted. And here we can see Richard Gracie, who first developed objective metrics for measuring pain, okay? Here you can see an example. We made an investment, 21 grants, resulted in 18 publications, 42 patents, and 24 drug products that are critical to helping with pain. One example was by an investigator, Mitchell Max, who had funding back in the 90s that resulted in 3 publications and multiple patents filed for dextromorphan. And why is dextromorphan important? It's now being used to treat diabetic peripheral neuropathy, herpetic neuralgia, and also chronic pain. What about our skeleton? Okay. For the last 25 years, there's been some work that's focused on this fibrous dysplasia McCune-Albright syndrome. And this genetic mutation actually impairs the skeletal stem cells' ability to become mature bone cells. So there's a natural history study. It has enrolled over 300 patients and has really transformed care for these patients because we now have denosumab as a treatment that seems to be very helpful to helping these folks so that they don't have the same level of skeletal fracture and pain as they were having in the past. And there are pediatric trials underway. We've learned now that there are cavity-causing bacteria, and I'm not sure why my movies aren't working here. Oh, there we go. Cavity-causing bacteria that can actually take a ride on the back of fungi, and they create together these superorganisms that can walk across the teeth to spread the biofilm, okay? We now know that silver diamine actually halts decay in young children, and this trial was so effective that it had to be stopped at the interim analysis. But what we also know, and critical to what you're doing at AT Still, is that integrating oral health into primary health care is critical to addressing oral health disparities and reaching children and adults in need. And then finally, the microbiome. You know, we're all talking about the microbiome now, but the microbiome began in the mouth. That was where it was first discovered, and this is where things first moved forward. In 2002, NIDCR founded the Multi-Institute Microbiome Field Research Program. In 2007, after new technology made the study feasible, an NIDCR person became the lead for the NIH Human Microbiome Project and the launch of the microbiome database. So NIDCR has been there, has helped to move some things forward, but there's a lot of work left to do. So we have several signature initiatives and collaborations that I'd like to share with you. And then after that, we'll finish up and I'll take some questions. So these programs include a community-based participatory program or consortium that's called ADAPT to help advance data, practice, and transformation that I think was a great potential opportunity for AT Still. The Shogers team for Accelerating Medicine's Partnership or STAMP. The HEAL initiative you heard a little bit about already. The practice-based research integrating multidisciplinary experiences into dental schools. You're aware that we already have a national practice-based network, but this was based in dental schools. And then we have the Head and Neck Cancer Early Detection Program and the TMD Collaborative. All of these initiatives come together to form this phrase, okay, which shares what our intention is, and that is to adapt and aim to heal while primed to move ahead with impact. So let's start with ADAPT. And the goal here is to form a research consortium to support community-based participatory approaches to design, implement, and evaluate population-based intervention strategies for reducing dental caries disparities and inequities. Here, we're wanting to use community engagement and data science to acquire the evidence that we need to help diminish oral health disparities. And we're partnering with the National Institute of Minority Health Disparities on that. There's the Sjogren's Team for Accelerating Medicine's Partnership. This is an AIM initiative where the partners and collaborators extend beyond NIH to industry and foundation and multiple foundations. And here the goal is to recruit large groups of Sjogren's patients and healthy participants that really help us understand the biology of Sjogren's disease with the goal of having better diagnostics, better standards of care, and finally good therapies for people who have Sjogren's disease or other autoimmune diseases that result in diminished salivary function. And here again, we're working with multiple NIH institutes as well as these industries and foundations. And the institutes who are involved are UCSF, Oklahoma, Johns Hopkins, and NIDCR. For the Helping to End Addiction Long-Term Initiative, or HEAL, there are two major projects for NIDCR. One is focused on restoring joint health and function to reduce pain or rejoin. And here the research is focused on mapping the network of sensory nerves that actually connect to the TMD and also to the knee. So we really try to understand how types and patterns of sensory neuron networks in joints change with disease and aging. The second one has to do with buprenorphine, which I mentioned earlier. Buprenorphine and other pharmacotherapies to treat opioid use disorders, as well as opioids themselves, cause serious xerostomia and have been associated with rampant oral disease. So this focus is on how we can understand how these drugs cause oral complications, and we're working together with NIDA, the National Institute of Drug Abuse, and Complementary Health. And in fact, you can see that the FDA has a warning on the label because there's so many dental problems associated with buprenorphine. Okay. Finally, so we aim to adapt and are primed. Okay. PRIME stands for Practice-Based Research, Integrating Multidisciplinary Research Experiences. And the focus here is to really bring practice-based research into the dental training curriculum, engaging dental students throughout their education, as well as, dental students, trainees, and faculty and staff with opportunities focused on developing clinical research skills, mentoring, and institutional collaborations. For opportunities to even do multi-site trials across these institutes. And here we're partnering with another institute, NCATS, okay? And here actually is the preliminary group of individuals associated with PRIME, but again, the goal is fostering a culture of scientific inquiry during dental education and encouraging partnerships. Okay. As this moves forward, this may be something that AT still can become a part of. I mentioned multiple times the challenge that we have because we don't have good biomarkers for early detection of cancers. So we really need to move forward and accelerate the translation of this research so we can develop, evaluate, and validate biomarkers for risk assessment, early detection, and molecular diagnosis of head and neck cancers. And this is a collaboration that we have with the National Cancer Institute. Okay, so we aim to adapt and are primed to move ahead for the Advancing Cancer Initiative. And here you can see the different the geographic locations of the different projects that are associated with this early detection research. Okay. And finally, we want to move ahead with impact. Impact stands for the TMD Collaborative for Improving Patient-Centered Translational Research. Okay. So we really need to move TMD basic and clinical research into improved clinical care. So what we've done is develop and establish an interdisciplinary trans-NIH patient-centered research collaborative focused on TMD. And this includes not only NIDCR, but the Musculoskeletal Institute, the Engineering Institute, the Neuroscience Institute, Complementary Health, Office of Women's Health, Behavioral Health, and even the FDA. Okay, and here you could see the geographic layout of the different projects associated with this initiative. So again, towards oral health for all, we aim to heal and adapt and are primed to move ahead with impact. This is not only a list of our initiatives, but importantly, it is our intention. We have to move ahead with impact. We have to move beyond these disparities. And in fact, our NIDCR strategic priorities are all aligned with the elimination of disparities. One, to integrate oral and general health. Okay. Two, precision dental medicine. Okay. You have to have both biologic and social determinants data to understand specific needs. And we're also working to target NIDCR technologies to underserved markets. Three, we've got to translate what we're doing, translate and implement the work. And we've got to make sure that translation happens to the widest population, the widest possible population demographic, to make sure that we've got tools to facilitate preclinical and clinical trials and ensure that there's diversity not only in our science, but in our trials. Four, to ensure we have a diverse research pipeline and to really nurture this to deploy important scientific efforts and to disband disparities. And finally, to partner and collaborate. And partnership means partnering with institutions like your own, but also, as you can see, we're working across many different agencies and different institutes. There is awareness of medically necessary dentistry. And in fact, the House Labor and Appropriations Bill that was spearheaded by Senator Cardin affirmed that dental care is integral to the medical management of multiple diseases and medical conditions. And they urge NIH to continue to fund additional research in this area and conduct trials to understand how oral care interventions can be effective for improving medical management and reducing the prevalence of multiple diseases and problematic areas. Okay. We continue to promote science that reflects the affected population. We have solicited and unsolicited disparities grants in clinical research and also behavioral research. Again, there's a community-based participatory research that I shared with you. And here, if you go to this QR code, you can see all of the different opportunities for different applications that are available to do this type of science or ask these types of questions, okay? And then finally, we're working on building a resource for the community that we call DDS, that stands for Data-Driven Solutions or Science, where we can glean insights from data from the molecular level to the population level to identify health disparities, help find root causes, and craft targeted interventions towards reducing these disparities. Okay, and we're actually collaborating with NIMHD there as well. So the data hub for our dental, oral, and craniofacial community will be released at the end of this year. And I look forward to your engaging with this hub. Okay, because this will be a critical centralized resource that will help investigators with current information about available scientific data, about biospecimens and other experimental material, resources and tools. So it'll be a great a resource for you and for all of those across AT Still who are interested in doing work with data or doing any secondary data analysis. Just sharing as I close that we did receive a congressional resolution this year honoring NIDCR and its critical role in improving dental, oral, and craniofacial health in the U.S. through research, training, and dissemination of health information. But there's much more work for us to do. And I look forward to engaging AT Still as we move forward to do it. I thank you. and look forward to any questions that you may have.
Again, thank you so much for being here with us today. We really appreciate your involvement and your dedication to research and scholarly initiatives. So to start off, my sincerest thanks goes to Dr. Webster Syriac for her insightful keynote address. We have already learned so much, and the day is early. My name is Gayla Sablet, and it is my honor to serve as ATSU's interim president for the Missouri campus, and you might know me in my former role, vice chancellor for research and grants. I'm sharing the stage today with my distinguished ATSU colleagues, Dr. Ann Spillerich, Dr. Hanan Omar, and Dr. Kim Perry. Thank you. To begin, my background is in research and grants administration, and I will start the panel by giving a brief overview of ATSU and its research and grants infrastructure. Research is part of ATSU's DNA, if you really think about it. It starts at the mission level and then builds and permeates from there. As I bolded here, ATSU is indeed a health sciences university with trained research faculty and teams, and scholarship is literally spelled out in our mission statement. Because of this, we have an ample research and grants infrastructure in place to keep our faculty and university both research and NIH grant ready. ATSU's vision in brief is to be the preeminent university of the health professions and a leading innovator in health professions education. Just like our mission, and as I bolded here, ATSU's long-term vision speaks to advancing scholarship and pioneering contributions to healthcare education, knowledge, and practice. As most of you know, ATSU has 3 campuses in Arizona, California, and Missouri, including the impressive St. Louis Dental Center just across the parking lot here, which is a critical part of our Missouri School of Dentistry and Oral Health. In total, ATSU has 7 prestigious schools, including 2 dental schools, 2 osteopathic medical schools, and 3 health professions graduate schools. These schools and colleges offer 15 doctoral level programs, 15 master's degree programs, and 19 online certificate programs. Here are some quick facts for us all to look at today. ATSU has over 3,500 unique students, with many seeking 2 or more graduate degrees or certificates. ATSU also has nearly 1,500 full and part-time employees, and one of the best workforces I know. ATSU is the proud home to the founding College of Osteopathic Medicine in Kirksville, Missouri, which has been in existence since 1892. As a result, ATSU has produced more than 37,000 graduates. At present, we have nearly 26,000 living alumni. Next up is a brief overview of the research culture and our teams. ATSU proudly supports faculty-led and mentored scholarly pursuits across all colleges and programs. To this end, we have a university-wide research division, the Research Grants and Scholarly Innovations Division, comprised of 3 departments that you may be familiar with. They are sponsored programs, which is the grants office. We also have research support and AT Still Research Institute. Our experts wrap knowledge and resources around faculty in support of basic, clinical, translational, and educational research. The division is the go-to place for all grant-sponsored activity, biostatistics, publication support, and a lot more. Over many decades, our university built up the supportive scholarly infrastructure that strives to keep all of ATSU research ready and grant ready, and really even more than that, competitive. A key part of our infrastructure is indeed sponsored programs, the Sponsored Programs Office, which is made up of a team of highly accomplished grant professionals assisting our faculty in locating, competing for, and winning, and also effectively managing extramural grant funding in support of research and scholarly activities. Sponsored Program specializes in HRSA and NIH grant funding mechanisms, as well as all other federal, state, and external grant opportunities. Over the years, this experienced grants team has helped local investigators win millions in grant awards at ATSU. While fiscal year 24 data is still kind of rolling in, here we depict fiscal year 23 grant funding outcomes. A total of $5.6 million in grant funding was awarded to ATSU in fiscal year 23 across 42 awards. Well done, you. As a non-research intensive university, the majority, and we're talking 76%, is from federal sources, specifically from the Health Resources and Services Administration for service and educational awards. In terms of NIH grant funding and looking over the last 5 fiscal years, ATSU investigators held just over $1.54 million in active NIH awards and sub-awards from these institutes. Our NIH activity codes or funding mechanisms include U01, R15s, R21s, and R01, and a collection equity award. It is important to note that other than the R15s, all are sub-award pass-throughs to ATSU from larger research-intensive universities like Arizona State University, Illinois State University, Penn State, and the University of Georgia. Although ATSU held R01s and R21s and the like in the past, as prime recipient, the R15 mechanism right now reigns supreme at ATSU because it's for research scientists that have not been major recipients of prior NIH support. Most of our current faculty fall into this category, so we hope to explore this topic a little more as the day goes on. Getting back to our infrastructure, next up we have ATSU's research support team, which consists of experts in designing a research study, preparing an IRB application, data mapping, collecting and analyzing data, survey development, publishing manuscripts, and more. This team includes certified research coordinators, biostatisticians, and an accomplished scientific writer with broad peer-reviewed journal expertise. Our research support team also assists with various campus research events and studies, further expanding the capabilities and the bandwidth of our internal research faculty. And finally, we are the proud home of the A.T. Still Research Institute, which seeks to advance whole person healthcare and wellness through development and support of premier clinical and translational research. The Research Institute was established in 2001 and operates 3 distinct centers listed here in the research areas of osteopathic manipulative medicine, oral health research, a big topic for today, and community health research. In particular, the Center for Oral Health Research is very supportive of clinician researchers who are interested in advancing translational research in oral health, a lot about what Dr. Webster spoke about today. I will now pass the torch to my esteemed colleague, Dr. Ann Spilarich, who will tell you more about the Center for Oral Health Research and ongoing research efforts at our Arizona School of Dentistry and Oral Health. Thank you.
Thank you, President Sublette, and thank you to your remarkable team, because all of us who conduct research can't do what we do without you. So thank you very much. So good morning, everyone. I'm Ann Spilarich. It's my honor and privilege to be here today. I'm going to share with you a couple of different pieces of information. First, I'd like to speak to you a little bit about the Still Research Institute Center for Oral Health, and then I'll switch gears and tell you a little bit about what's happening at ASDO. So the Center for Oral Health Research was established in 2016, and it really came out of the growth of our two dental schools and recognizing the tremendous initiatives that were in place in helping to promote oral health improvements in the United States. Our mission is really to promote whole person health by translating outcomes gained from clinical, behavioral, and exploratory research that will translate into advances in dental education and practice. And ultimately, the goal is to not only expand the science base of dentistry, but that information is used to support both evidence-based decision-making and evidence-based practice in support of whole person wellness. Now, whenever you start a new center, we have to think about what are the goals of this center and how are we going to go about supporting the mission and reaching the goals. And so we determined a long-range plan, setting apart some goals to help us target our research initiatives. And many of them align and support with the recent update to the definition of oral health by the World Health Organization that really closely aligns with what we just heard in terms of initiatives from NIDCR. So our long-term goals for striving to support research initiatives really are to promote oral health as an essential component of whole person health, to develop the skills of our faculty and students that will ultimately lead to research independence, to increase the breadth and scope of research and scholarly activities of our ATSU faculty, and finally, to develop, implement, and disseminate innovative strategies to improve the oral health of the public, especially among those who are underserved. The overarching intent of the Center for Oral Health Research is to establish an infrastructure to support the growth of a cadre of researchers who possess the skills to not only conduct research, but to mentor novice investigators, including faculty and students, and ultimately to serve as the leaders in the translation of the knowledge that we gain through our research activities into translational events in the curriculum and dental practice. So the center has 7 items on its research agenda. And like all good research agendas, this is a dynamic document. It changes in time as we see some of our major funding agencies and global partners in oral health, and they evolve and change in their priorities. So I'll tell you a little bit about them. So we support interventions that improve the oral health of specific population groups and best practices for treating patients with special healthcare needs. We support exploratory research to improve diagnosis and treatment of oral conditions, and to identify, develop, and test different delivery models to improve access to care. We also like research that looks at the cost benefit of different oral health interventions to improve systemic health, and look at ways that how the influence of general health and oral health behaviors affect overall health and wellness. And finally, given our mission as a university with a strong public health emphasis, we are interested in looking at the impact of having a public health education on practitioner attitudes towards treating the underserved. We all know that research is never conducted in isolation. We never do this alone. And so part of the mission also of the Institute is to look at how do we engage strategic partners to help us to address our research initiatives. And I have just a list of some of those partnerships here that many of our faculty are engaged in. And what you can see, we partner with major research intensive universities, also area hospital and academic hospital settings, different types of foundations and professional organizations, and our partners in private industry. One of my favorite parts of being a center director is looking for ways to support the center's Student Clinician Researcher Development Program, which we nicknamed the CRDP. ASDO has been very fortunate to have many students who have gone through this program. And the goal of this program is to really help to mentor students who have an interest in clinical research and to provide them with the skills and the resources that they have to prepare them to hopefully continue to participate in research after graduation and they enter the workforce. Our latest student who graduated from this program actually did 2 projects, and part of that program was involved at the NIDCR Dental Student Summer Research Internship Program that actually takes place in Bethesda. And then she also later did another research project in partnership with her dual degree MPH program, looking at really interesting population of adolescents who are in juvenile detention and looking at their patterns of substance use before and after the pandemic. And that manuscript is in development. And I'm really excited because today and very soon you'll get to hear from one of our graduates of this program, Dr. Samantha Yinneman, who I have the pleasure of getting to work with every day. So now I'm going to switch gears and put on my hat as the Assistant Dean for Research at ASDO and tell you a little bit about what's happening at the dental school. So ASDO has a very robust research program, and you can see from the numbers here, we have a lot of engagement by faculty, residents, and students. And we receive funding support for many different types of research activities through federal sources, foundations, private industry, as well as ATSU's internal grant program. We also house the Oral Health Research Center, which is part of the Dillenberg Center for Technology and Innovation at ASDO. And through some generous private donations, we have built out a clinical research component to the center that has 2 designated operatories where we run clinical trials. And then we have the only wet lab on the Mesa campus. And this center is available for anyone to use across the university. And in fact, we really encourage and enjoy many interprofessional activities in our center. ASDO has a very wide breadth of the types of research projects that our faculty, residents, and students engage in, but you can see them listed here. This is some of our major primary focus areas. We have a reputation for our expertise in caring for people with special healthcare needs. So we do a lot of work in populations with disabilities and medical complexities, including cancer. We also are involved in quite a bit of educational research, looking at the use of technology, as well as some new innovative curricular models. And you can see the list there. We do quite a bit of research in orthodontics, as well as imaging and oral facial pain, as well as models of different care delivery, especially in the area of teledentistry. So I wanted to just quickly highlight a few of the larger funded projects that we have going on and tell you then a little bit about our student research program. So we have a wonderful partnership with Arizona State University and the Baylor College of Medicine. This is an HPV biomarker study that is supported through the National Cancer Institute. And through this grant, we have established the Southwest Early Detection Research Network. So there are many EDRNs that have been funded across the country. So we are the newest EDRN. And the goal is actually to develop ultimately a point of care diagnostic test that dental professionals will be able to use for the early detection of HPV related oropharyngeal cancers. And this is the same group who developed the salivary diagnostic test for COVID. So they also have a whole tech group that's also working with our team. So ASDO has a very large population of patients with head and neck cancers who we treat, and we will be collecting saliva and blood samples from this patient population, as well as some control subjects, to validate the technology that has been developed for early detection. And this is a 5-year award from the National Cancer Institute. And the last phase of this study will be collecting thousands of samples to build a biorepository in the southwestern part of the United States for members of the EDRN and other scientists across the country to be able to use to further research in HPV. We have two models of care that I'm going to highlight here. One is to flip the script a bit and to put a medical professional into a dental clinic. Most of the work that's been done previously has been to put a dental professional into a medical center, right? So we're turning it the other way around. And we're using a member of the faculty from our PA program, and we are going to be looking at cost effectiveness and feasibility of this model. We also have a new teledentistry model that is designed to partner with 5 FQHCs and CHC sites around the state of Arizona. Oral pathology services are quite limited in our state. We're very fortunate to actually have the only 2 oral pathologists in the state on our faculty, one of whom is an ASDO grad. And we're going to be looking at ways to help our partners in the community who have patients with pathologies so that we could use asynchronous evaluation of their pathology to determine next steps for evaluation and monitoring. We also have quite a bit of work that's going on in the area of diagnostics and imaging and AI. Technology, of course, is a big focus for many dental schools. ASDO is the 5th dental school in the country to have acquired through a grant a tomosynthesis machine that allows 3D imaging of the oral tissues. And we're doing an interesting endo study right now. And we have many studies involving the use of ultrasound. And my colleague Inder Makin is here, who does quite a number of those studies, also has that relates to the TMJ. And several studies going on involving artificial intelligence, not only in terms of clinical assessment, but also using it in an educational setting. We were fortunate to partner with our colleagues at SOMA, who received a large HRSA grant looking at behavioral health integration into primary care. And one of the outcomes of this 5-year grant was to develop a new training curriculum for D3 students to teach them how to manage patients with mental health disorders and substance use disorders. We actually have had a really great time teaching this. This is interdisciplinary. We have medical faculty as well as our social worker at the dental school. I get to teach with them. It's such a joy for me. And we have lots of different innovative teaching strategies, including standardized patients. And we just presented the first 2-year outcomes from our student learning at the ADIA meeting in March of this year. The last model I'll tell you about is there is a huge workforce shortage of people who are working to intentionally treat people with disabilities. And we have been funded through HRSA to include many different aspects of training in this area, one of which was to create a model to allow students from 5 area dental hygiene programs to not only receive didactic training, but to rotate through our advanced care clinic to have hands-on training. And we collected data over 5 years, over 300 students who were trained. And we actually just published this model, and it was so well received that it was actually invited to be dual programmed in an international, published in an international journal, sorry. And so we're really excited that we're getting this model out into the world and hope other people will be copying that from us in their workforce training opportunities. And last but certainly not least, our student research program has really grown exponentially in certainly the 9 years that I've been at ASDO. We have actually a little bit of a different model than what you'll hear about here at MOSDO, but research, like in all dental schools, is incorporated throughout the integrated curriculum, so where students learn basic principles of research and methodology and statistics. But conducting research is actually an extracurricular activity at ASDO, so students have to get approved to participate in research, and they can begin as early as January of their D1 year. I am of the philosophy that students should study what they want to study and what they're interested in. And so I would say that the overwhelming majority of our projects are student driven, as opposed to tagging them onto a faculty project, although we certainly do that as well. I'm very, very proud of our students. They have a 100% success rate with their grant awards for not only internal grants, but also external grants. And there are very high expectations for those students to disseminate their work. And so we have 2 research events at ASDO. We have a fall research day in September coming up in just a month. And then we have Research Week, which is in February every year. Our students also present in the university's Interdisciplinary Biomedical Sciences Symposium, as well as at a whole host of national and international meetings, as well as publishing their research. We also have students who engage in many national competitions with their research. This year, I have to just brag a little bit because in the upper right, that's our student Christian McSweeney, who was one of the winners at the prestigious Hinman Student Research Competition hosted by University of Tennessee. And 2 of our newly promoted D3 students who as D2s presented at the American Academy of Sports Dentistry meeting and came in 2nd place for their research on our team working on with International Special Olympics. And last but not least, we just formalized our first chapter of the AAGOCR National Student Research Group. So we are on our way and got a lot going on. So you're certainly welcome. And I encourage you, if you have any questions or comments, please always feel free to reach out to me. Thank you so much. And I'm now going to turn this podium over to my good friend, Dr. Hanan Omar.
Thanks, Dr. Polarich. I'm Hanan Omar. I'll be sharing with you a bit about our MOSDO journey in achieving our research culture through serving underserved population. So I would refer to MOSDO as a tale of 2 cities because we are really 2 cities. So we are based in Kirksville and St. Louis. Although we have more than 3 hours separating both sites, but we share the same vision and mission towards helping the underserved population. A bit of background about MOSDO. Our first class of 42 students entered in 2013. Through our strategic partnership with Affinia Healthcare, we were able to achieve our learning model and achieve our clinical experience for our students. More collaboration and strategic partnership with more than 60 federally qualified health centers and community health centers to support our clinical education and the educational experiences for our students. With our mission to be an innovative, socially responsible institution committed to whole person care, we have touched the lives of more than 36,000 patients between the years of 2019 and 24. With our collaboration with other schools and hospitals, we were able to support the underserved population, and we also raised funds to support veterans and elderly population of Missouri. When it comes to our second aspect of our mission, where we are looking into scholarship and community involvement, we have secured federal funds as well as external and internal grants. So as you see in those 2 tables, that the federal funds addressing the social determinants of health, also supporting the vulnerable population through our transformative approach to our predoctoral education. Another fund was secured to support the veterans and improve their oral health. With other external grants supporting oral health of all population through a COA grant that has been going for more than 2 years. And you can see also that we have a language improving grant that supports to overcome the language barriers of the patients and underserved population. In addition to other internal grants that looking into student doctors as translators, and the assessment of cannabis use by patients seeking dental care, in addition to technology-enhanced learning initiatives that is supported by our internal grants. When we look at faculty publications over the years, we can see an increase in number of faculty publications starting from 2020, reaching up to 2024. And we can see we have 23 publications this year. And actually, as of yesterday, they became 24, where two of our clinical faculty, Dr. Harry Babu and Dr. Vij, addressed the Kaposi sarcoma condition in a new publication. Our research areas expanded from periodontics, case reports, educational research, as well as digital dentistry and implant dentistry. This shows a large area of research where our faculty are involved and engaged. These are some examples of the faculty publication that has been going on for the past few years, where we are looking into different aspects of dental education, as well as improving and enhancing dental materials research. Last but not least, we are proud of our dental students research model, where the students research is part of our curriculum, and D3 students both in their fall and spring semester, supported by our faculty, they complete a whole research project. We celebrate their successes every year through our research day that happens in April, where the students present their findings. And we also encourage them to present in other scientific conferences, where we have our students presenting in Hinman Dental Symposium, ADEA, IADR, and AADOCR, and competing as part of the SCADA competition. And with that being said, we are hoping to more collaboration between our school and ASDO, where we are going to work together to achieve better outcomes for our patient and more research outcomes. Thank you.
Good afternoon. My name is Dr. Kim Perry. I'm a dentist and excited to have the opportunity to chat with you today. So my topic will be about AT-STIL's pathway to practice for equitable community health, the university's mission, our investment and support. AT-STIL University is deeply committed to advancing equitable community health through a pathway to practice strategy. This comprehensive initiative focuses on strengthening the healthcare workforce in underserved areas by attracting, educating, supporting health professionals who are passionate about serving these communities. The university's investment in this strategy demonstrates our dedication to addressing health disparities and ensuring that all individuals have access to quality healthcare. When we look at our mission focuses on whole person healthcare, focuses on scholarship, community and population health for who? For all of us. Interprofessional education is huge because we know that there's a need to integrate oral health, primary care, and behavioral health, as well as diversity and underserved populations, all the while maintaining its commitment to our osteopathic heritage. When we look at our strategic plan, AT-STIL core institutional values are about innovation, as you can see with the development of our programs, whole person healthcare, leadership in the community, diversity, as well as scholarship and research. Also within our strategic plan are our core professional attributes. So we want our students and our graduates to be clinical thinkers, right? Culturally proficient, to be able to deal with the patient populations that we know are in underserved communities. Having those interprofessional skills, as well as interprofessional collaboration with integration will be important, and our social responsibility. And that's one of the reasons why many of our students receive their clinical education in community health centers. So our social mission, it's the why behind our alliances with the National Association of Community Health Centers, primary care associations, and our CHC partners. When we look at NAC's mission, it's about high quality care, comprehensive health care, care that is culturally and linguistically competent, it's community focused, and patient centered for who? For all. We know that community health centers provide care to 70% of underserved patient population, and that's our rationale for our alliances, our models, and growing our own. AT Still's solution to improving outcomes in medically underserved communities, it's our commitment to our social mission. It's our commitment to our alliances and our community stakeholders, as well as the strategies that we have developed to improve patient and community outcomes. As you've heard, we have 7 colleges on 3 different campuses, so we're really excited about that. We know that the majority of AT Still students receive their clinical education in community health centers nationally. And we also know that 77% of AT Still graduates choose to complete their residencies in medically underserved communities, and 69% establishes their practice in those same communities. When we look at KCOM, our medical school in Kirksville, Missouri, we're excited to find that KCOM provides support to community health centers nationally for those who are looking to develop teaching health center graduate medical education programs and rural residencies. And in 2023, KCOM with the Still Opti component partner with Affinia Healthcare, which we know is our partner here in St. Louis, and Christian Hospital. And they were funded to develop a HRSA family medicine residency grant. So we're excited about that. We know that KCOM ranked #1 in graduates providing primary care in rural America, and number 28 of working in shortage areas. Looking at our medical school in Arizona, SOMA was founded in 2007 under the ask of the National Association of Community Health Centers. It has partners in rural and urban communities, and this class size is about 160. They have 11 community partners that they work with nationally, and 72% of AT Still graduates are practicing in medically underserved communities. These students, along with our ASHA students, work with the community health centers to ask and answer those research questions that we know are desperately needed to improve outcomes in those communities. And they present their capstone projects at the CHI with the National Association of Community Health Centers. Another initiative through SOMA is a tailor-made program. So we have individuals who have the heart to want to become physicians, but may have some challenges academically. So SOMA, under the leadership of Dr. Obadia, has created the tailor-made program to help those students so we can, once we identify them, they can matriculate and we can graduate them and send them back to their communities and provide the care that we know is so desperately needed. We know that SOMA was ranked #6 in the nation for graduates actually practicing in primary care, and #44 for being the most diverse medical school in the country. When we look at MOSO, Missouri School of Dentistry and Oral Health, we know that they are on board with the Hometown Healer Strategy program, and you'll hear a little bit more about that, where we identify individuals in the community to want to become dentists and go back and work in those underserved areas. We know that the dental center hires local dentists to be able to provide the clinical education to our students. And we also know that about 50% of the employees at the St. Louis Center live in those communities. We know that MOSO has had about 233,000 patient visits, 197 at that St. Louis Center, so we're excited about that, and about 36,000 urgent care encounters. We know that MOSO has graduated about 7 classes, and the growing number of those alumni are working in community health, working in vulnerable and underserved communities. When we look at ASH's program, we're really excited. So they're in rural America and across the country as well. They're doing some research with the Rural Health Group at Community Health Center. So you can see that some of the research is focused on smoking cessation, nutrition, as well as substance use disorders. And so we're really excited about that. But what we're really excited about is Raven Bureau, who's a PA, has decided to go back and provide care in the Mississippi Delta. And not only that, Raven married a dentist from ASDO who is now they're both going back and working in those areas. And that's what it's all about, being able to graduate folks with the heart, and they go back and provide the care that we know is so desperately needed. When we look at CHC Colleges for Healthy Communities, which is our Central Coast PA program in Santa Maria, who has partnered with the community health centers, we know when we look at their commitment to community health centers, a high percentage of those graduates are working in community health centers. When we look at health shortage areas, 69% of those are working in medically underserved areas. Focusing on primary care, 28% of the CCPA graduates are working in, have chosen primary care as their area of specialty, which exceeds the national average. When we look at the student body composition in this college, it's very diverse, as you can see. And we know that ultimately, this will improve outcomes in this farm worker community in Santa Maria. When we look at the College for Graduates with Health Studies, they have multiple programs here, which is just absolutely amazing. And it provides folks who are working to have an opportunity to elevate their educational experience where? Online. We know that this program has about 829 students. We know the average age is about 36, so they're an older group. We have graduated about 3,600 and provided about 1,900 certificates to these graduates. But what we're really excited about, their new initiative, is Be the Leader Underserved Communities Need. So under the leadership of Dr. Hasty and working with Dr. Allen Freeman, they have developed something called the Graduate Certificate Health Administration for Community Health Centers. And what this health center leaders, and what this does, it gives individuals who are working in community health centers an opportunity to ladder up. So we're excited about that. Not only that, there'll be a $25,000 opportunity for scholarship for those successful individuals who are accepted into those programs, as well as a 20% tuition discount will be available. And these are for individuals who work within NAC and within the community health centers. Another initiative that we have, particularly in the area of research, so in 2017, AT Still partnered with the National Association of Community Health Centers and developed the National Center for Community Health Research. The focus of the mission is quality research for who? Underserved and vulnerable populations, and the focus is on health equity. Another particular really important area is the quadruple aim. And we know that AT Still provides IRB support, research study design, statistical assistance and publication to the community health centers and to NAC. And currently, this center is under the leadership of Dr. Joy Lewis in Soma. So we're excited about that. Some of the outcomes from this collaborative in this center are grants around influenza, grants around heart attacks, strokes, as well as cancer, and Million Heart Study, and a training program. So we're really feeling like we're moving the dial in this area. But of course, there's definitely more work to be done. There have been publications that have been developed, particularly some with athletic training, Million Hearts, and the Elevate Project. Additional research initiatives that we have is the Community Health Research Work Group under the leadership of Dr. Marie Jackson, where she is collaborating with the community health centers and beginning to ask and answer some of those questions that we know impact those communities. Another initiative is a research summit. So annually, AT still meets with HRSA, CDC, and the National Association of Community Health Centers to identify those initiatives that are important to those communities so we can begin to do the research that's needed. Our hometown scholar strategy, as I've shared, what it says to the community are there any individuals who would like to be physicians, dentists, PAs, who have the heart to want to come back and provide the care that so desperately is needed? And so what we ask to those community leaders, I say, hey, are there any individuals working in your community health centers that you're willing to endorse? And what we do as an institution, we give them an opportunity to get an interview. So it's our way of helping that pathway back to those communities to provide the care that's needed. And as we begin to close here, what our partners say to us, the community health centers, they provide majority of our clinical education to our students, but they say to us, can you identify some who can come back and provide the care that's needed? So we partner with MOSDO and ASDO and ASHES to conduct twice a year in-person and virtual community health fair recruitment fairs. We have been very successful. When COVID, we went strictly online, and we have been very successful. So this is our last one in 2023. They've been growing over the years, and the community health centers love to participate, and the students have been able to learn more about the community health centers in a hope that they would choose them to do the care that's needed. The last initiative we have, and something that we're working on, one challenge that the community health centers are saying to us, how do we get more of our medical providers back into those communities? So in meeting with the Dean of SOMA and talking with the Dean of KCOM, things that we're talking about is how can we identify those community health centers who have residency programs, invite them to what we're calling a medical residency fair for the third year medical student before they match, giving them an opportunity to learn more about those community health centers because they're needing to do their residencies. They're not like us, they're not shovel ready. They can't go straight into practice. So we're trying to, we believe that this effort will be very helpful in connecting them so they'll choose a community health center to do their residency program. So I'd like to thank you. And this is AT Still's way of living our mission. So thank you.
Good afternoon, everyone. We're going to continue our program while you finish up with lunch. Our topic that we're on at this time is Priming the Pipeline, ATSU Student Research Stories. And it is my distinct pleasure to present to you ATSU Moses graduate and researcher, Dr. Josh Coffey. He's a graduate of the class of 2018. He went on to pursue a degree in oral maxillofacial surgery. He finished up his program in 2023. Now he's back in the area. He practices in Chesterfield, Missouri, and has actually been very instrumental in helping out with the veterans program, Smiles for Veterans. He has helped us in Dexter and has pledged to continue to support us. So again, please welcome our proud graduate, Dr. Josh Coffey. Thank you.
Thank you, Dr. McLeod. I'll try to pull this off without breaking anything. Okay. Thank you guys for having me. I feel very honored and privileged to have been invited to this. I recognize a lot of really good faces and people that I knew once upon a time. But it's nice to be back here in St. Louis, here in Lafayette Square. It's very, very familiar to me. I'm appreciative to the speakers that have already shared some messages with us. Very broad. There's been a lot of updates on the current state of research at ATSU and some ideas on how we can improve even in the future. So I don't know how much I really have to add, My goal today is just to basically share my personal experience, kind of where I came from, and how I was able to participate in the research process kind of throughout my education. So hopefully there's something that I mentioned today that's maybe valuable. But I was born in St. Charles, just right up the road. Born and raised here. My goal was always to come back to St. Louis. I did my undergraduate at Brigham Young University. I was in the music education program there. My goal was to be a music teacher. And after a year, I took a 2-year hiatus. I served a mission for my church. A lot of that was proselyting. A lot of that was just service. Talked to a lot of people. And I ended up having a mentor that kind of steered me into the field of dentistry. I applied for dental school here at ATSU to be in the first graduating class, to which I was denied entrance. And I harbor no ill feelings, and I don't resent. No, I'm just kidding. It ended up being kind of a blessing in disguise. We had our first baby that year. We had our baby at home, and we had some issues that we were able to have family around for us. And I can't imagine going through that as a first-year dental student. So I was accepted into the second class, had an amazing experience at ATSU. I did my residency at Case Western Reserve up in Cleveland, Ohio, had an amazing experience there. Graduated just last year and have been back in town ever since. So with the risk of this sounding kind of like a travel log, I just kind of want to walk through the different research mentors that I have had and how they've kind of played a role in, not just my education, but in my life and in my family's lives. So the first person was Dr. Singh. This is a very skilled microbiologist up in Kirksville. I was plugged into Dr. Singh's research by Parker Crutchfield. I don't know what Parker's actual title was, but he was instrumental in helping me get plugged into several different researchers and kind of showing me what programs were available for me. But Dr. Singh's lab was very focused on Staph aureus, and I think probably still is. He's very widely published. But he started to dabble in some dental research whenever Mosdo opened, and we developed a project on looking at some different periobugs and quantifying them with qPCR, which I had no idea what qPCR was. I had never been involved in research before, so this was really my first benchtop experience learning, about pipettes and beakers and glassware and anaerobic growth chambers and all this stuff. And while I was thinking about presenting some of this, I was like, man, most of that has just completely left my mind. The one thing I remember about anaerobic bacteria is that they're very, very smelly. So I can share that with you guys. We were successful in developing an assay, published this, and I was able to present at what used to be Student Clinicians of the ADA. I guess it's now some competition. It's kind of changed names, but sponsored by Dentsply. But went out to Denver, was able to present that, which is a great experience. Dr. Singh and his lovely wife invited my family into their home once a month. We shared dinner together. These labs are families, and it's very, very cool to not just be a part of the education, but to be a part of the research family. So I'll be forever grateful to Dr. Singh. Dr. Crutchfield, or I guess not Dr. Parker Crutchfield, I think he's at Michigan now. Is that correct? I see some nods, maybe. So he was the one that told me about the AADR. He told me about the SCADA program. He taught me what the NIH was. I didn't even know. I come from no medical background of any kind. So the NIH and the NIDCR meant nothing to me until Parker kind of introduced the concept and recommended applying for their clinical research developer program. So I went online, I looked at the different researchers and the different labs that were at the NIH, and I found Nikki Moutsopoulos, who's a periodontist, very skilled. She's a boss. She is published in all the top journals in the world: New England Journal of Medicine, Science, Cell, Nature. Mostly what she's focused on is neutrophils and on immunology. But she would see very, very rare patients with leukocyte adhesion deficiency. This is an extremely rare condition, but they would come to the NIH to be studied, and she would take, biopsies, and she would study these things in her lab. patients with graft versus host disease. There was a lot of really cool research kind of going in and out of her lab. They would use a mouse model to induce perio disease. They would tie a ligature around the second molar using high magnification and then study the inflammatory cascade. Which is really cool to kind of participate in and see that. So anyway, I had emailed her and I was like, please, 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 please let me come to your lab and let me hang out for the 10-week program. And she was like, yeah, I can come up with some things for you to do. And I think she probably did not need my help in any way, but it got me in the door. Cool experience. Got to meet Anthony Fauci, got to meet Bernard Costello, and a lot of great oral surgeons that would come there and speak, and a lot of researchers from around the world. So really, really cool program. This is my program director. This is Dr. Qureshi from residency. Wrote several book chapters with him, published a lot of different case reports. The one that I included on here was a patient with slip rib syndrome. The cardiothoracic team approached us. They wanted a way to plate a few ribs using an autogenous graft. They'd kind of gone through the normal algorithm for treating this condition. She was a high school swimmer, going to be a collegiate swimmer, and just had tremendous pain with torsion and turning and everything else. And so we harvested. We do a lot of hip grafts in oral surgery, so we harvested a block of her iliac crest, which was then plated, and we ended up publishing this as kind of a new novel technique. So. But Dr. Qureshi was amazing, big advocate of the research process. This is Dr. Dale Bauer. He was our department chair up at Case Western. Also very much an advocate of research. And this is the thing that I'm going to talk about a little bit more. The paradigm for addressing large, like segmental defects in the mandible is anything greater than 5 centimeters would require a microvascular free flap. And this is an old paradigm from old literature where anything greater than 5 centimeters reconstructed with non-autogenous bone is going to fail. So this here is these top 3 pictures. This is a patient, she was maybe 16, 17, 18. This is like a fibroosseous lesion. I can't remember the exact diagnosis, but this is a resection. It's about a 7, 8, 9 centimeter resection. This is now, we have a dental cripple at a very young age that has to be reconstructed. Free fibulas work. They're widely used. The issue with a fibula is it's about the size of a dry erase marker. And dental rehabilitation is incredibly difficult. So our very skilled plastic surgery and ENT colleagues will use a free flap for this, a fibula for this, and then they'll send it to their local maxillofacial prosthodontist who has a very difficult time restoring this patient back to, both aesthetics and speech and mastication, and those things are very difficult to restore. So one of the things that we did a lot at Case Western was research tissue engineering, and certainly not the only program that would approach these cases this way, but with tissue engineering, you need some sort of a scaffolding, you need cells that have the ability to induce bone, and you need a signal. This is anterior iliac crest, able to harvest a 5 by 5 centimeter block, plus cancellous bone. You're able to get anywhere from 50 to 70 cc's of bone for a reconstruction. This is actually showing the same patient. I'm sorry for the graphic pictures if anyone doesn't like this kind of stuff, but so you have a custom reconstruction plate. In the middle picture there, you have those cortical block grafts, and then the picture on the right, you have your cancellous bone mixed with some BMP and some BBX as well. Tissue engineering made a huge leap back in the 1970s. There's a researcher by the last name of Urist. He was studying demineralized bone. And what he did was he implanted some demineralized bone into a little pouch that he created in the muscle of a rat in the thigh. And he found that this induced bone formation in an area that would not have had bone formation otherwise. Regular mineralized allograft did not do the same thing. which led him eventually to the discovery of a very special protein called, we now call bone morphogenic protein. He was nominated for a Nobel Prize for that. Later isolated an isotope of that BMP2. The trade name for that now is Infuse, if anyone has heard of that. It has been researched in bone grafting and like maxillary sinus augmentation and other things. The reason it's not mainstream right now is because it's tremendously expensive, but a wonderful adjunct to these types of grafts. We could probably skip some of this stuff. Here's your, this 8cc, that large kit is what we'd use for large bone grafts. That's about a $6,000 or $7,000 addition to the case. So this is what you have whenever you're engineering a new mandible with the right cells, with the right signals. You're able to form, basically like Play-Doh, you're able to form mandible in a correct location to where dental implants and future fixed work can be completed. And I guess I don't really have much else, but this is my family here. I had added one new daughter last week, so there's 4 little girls now, but thank you. Thank you so much. But you know, my interests in research have been kind of wide. I've just been appreciative for the chance to participate in the research process. At this point, I work for a very private practice organization right now where there's not a lot of research being done. It takes a long time to develop the referral base to start doing some of these larger cases, but that's certainly going to be an interest of mine moving forward. So thank you, guys.
Thank you, Dr. Coffey. That was great. We're very proud of your many accomplishments. Wonderful. It's my pleasure now to introduce Dr. Samantha Yinneman. We call her Sammy. I'm so lucky because Sammy was one of my former students. She's a graduate of ASDO. She has also received her MPH from the CGHS program and is also one of our advanced education in general dentistry graduates from our residency program at ASDO as well. And currently, Sammy is an assistant professor at ASDO, and she is the associate director of our special care dentistry program. Thanks for being here, Sammy.
Thank you so much, Dr. Spolarich. And thank you all for having me here today. It's truly such an honor to be here with you all. Like she said, my name is Dr. Sammy Yinneman. I'm the assistant director of the special care clinic. I graduated from ASDO in the Mesa campus in 2020. So I was the COVID class. And I graduated with my DMD and my MPH. And then I went to AEGD, also at ASDO, went out and practiced for about a year. And then now I'm back teaching full-time in the clinic. So they say it's like Hotel California. You never really want to leave once you leave. So just a little bit of background information. 1 in 4 adults have a disability. So that's kind of a huge umbrella. That could be anything really. A lot of times when you think a disability, you think kind of a mobile impairment. Patient uses a wheelchair, maybe a walker, but that could be a visual impairment. That could be a hearing impairment. That could mean autism. That could mean Down syndrome. That could mean cerebral palsy. It could be a rare disorder. So when we say a patient has a disability, that could mean a really wide variety of disability or conditions. So it's really, really important that healthcare providers are able and willing to safely treat this population. So that's kind of where this leg of research comes in. And that's why the American Disabilities Act was enacted in 1990 to protect people with disabilities from this discrimination. So all offices need to be able to be accessible with wheelchairs. Doorways need to have a width that allows wheelchairs to get in. We need to have communication services that allow patients to communicate with their providers safely and effectively. So at our clinic, we have iPad services that you can FaceTime somebody who's fluent in American Sign Language, or some people use Spanish Sign Language and you have to translate through a Spanish translator and then ASL. So all of that, as healthcare providers, we have to be able to do that for our patients. And competence, that's the big thing, to be able to treat and manage these conditions. So you kind of think about if you were to go to your healthcare provider and they were to say, well, you're blonde, so I can't treat you. That's what these people face on a daily basis, and it's really not fair to them. So that's why it's so important for all of us in this field of educating young upcoming healthcare providers to make sure that we're educating them on knowing how to treat this population, because then it plants these little seeds and creates this trickle over effect, allowing them to know how to treat them and thereby increasing access to care for such a marginalized population. So a little bit about my personal experience with this research. I picked up the second leg of this project when I was about a D3 in dental school. That's me on the right presenting at Research Day when I was a D4. I was selected for the ATSRI Student Clinician Researcher Development Program. And I presented at the ASDO Research Day in February of 2020. But I don't know if you guys remember Friday, March 13th, 2020. I remember that day very well. The world shut down due to COVID. I was taking boards. So everything that we had planned after that to present at Special Care Dentistry Association and the International Association of Dental Research, all of that got canceled due to COVID. So I think our abstract got published in those journals, but we weren't able to do any presentations, unfortunately. But we were able to do ASDO Research Day, like Dr. Splarich had mentioned, because that was in February. But then that carried over through my AEGD residency because we were able to do the final manuscript write-up during that time. So this was a set of longitudinal data collection where we surveyed the same cohort of dental students at different points throughout their curriculum, asking them their intent to treat patients with special healthcare needs after they graduate dental school. So as some of you might know, the ADA CODA standard recently modified its dictation in which students must be able to not only assess patients with special needs, but now they must be able to assess and manage treatment for patients with special needs. So a lot of new dental schools, or a lot of dental schools, are generating a special healthcare clinic within their curriculum to meet this criteria. And ASDO's always been ahead of the curve in that, because we've been training students with many board certified special healthcare faculty since the early 2000s. We've had a very well-established clinic, and we've been training patients in this particular area for a very long time. So we actually get a lot of people coming over from different dental schools, kind of looking at how are we running things, and they might take little tidbits and kind of mirror that off as they build their own special healthcare clinic. So some of the methods that were used for this study, we utilized the theory of planned behavior. So it involves, I don't know if you guys can see, but the concept that people's attitudes, their subjective norms, and their perceived behavioral control, all these three together combined, thereby predict their intentions, which then is a predictor of their future behavior. So I know it's kind of tricky, but those three concepts combined are meant to predict how a person is going to act in the future, per se. So this was taken directly from the International Association for Disability and Oral Health, a toolkit Dr. Denise Falks had fabricated that utilizes the theory of planned behavior. So this same set of survey, or the same questionnaire, was administered, like I said, to the same dental school cohort at 4 different points throughout their curriculum. So the idea is, what is your intention of treating this population when you graduate, in order to simplify it? So the first point, baseline before any exposure to special care. The second point was after they take a 2-week didactic course. And this is where they go to the activity center and they go just play dodgeball, they play bingo, they interact with this population, which a lot of them probably haven't before at all in their lives. They have a panel of patients with special care come. A lot of them, they're just selected from our patient pool. They come and talk to them. They take a didactic course where they learn a lot about them. And then point 3 is taken after 2-week-long clinical rotations as a D3. And then, because they do a week as a D3 in their first semester, a week in their second semester, and then same thing as a D4. And then point 4 was taken at the end of their D4 a year before they graduate. So these were the results of the survey. So as you can see, really strong data that supports that when our students leave and at various points throughout the survey that it was administered, the students had a very strong intention of treating patients with special healthcare needs. So we can infer that increased exposure to special care dentistry leads to greater confidence in their abilities and less hindrance in their clinical performance after they graduate. So one thing to consider here too is that we have a lot of students who may already possess an inclination just by nature when they come to ASDO. We have a public health oriented school. Some people, when they interview, they already come in and they say, I know you have a good special health or a good special needs clinic. I want to come here because of that. So there may be a potential bias at our school specifically because of that. Although this survey has been administered already throughout the country, throughout the world actually, but we see similar results across. So just because this particular study may have a bias to it because of ASDO, we're seeing similar trends throughout the world. Currently, this particular manuscript that we have for the research that I did has been written for publication. And we're just kind of waiting to hear back on that. So currently my position as full-time faculty, I am providing oversight for other projects for students regarding patients with special health care needs. We have 2 ongoing studies, one regarding Botox in patients with cerebral palsy. Botox has been known in other studies to help with bruxism by administering Botox into the masseter muscles and to help with sialorrhea. And that's planned to be presented in a poster at the Special Care Dentistry Association conference upcoming next month in September. And then one in endodontic testing in patients with Down syndrome. That'll be a clinical based study for which we received the ATSU Student Research Grant Award, which is very exciting. And the goal here is exposure and inspiration. Our hope is that as faculty that our passion in treating this population can be contagious to other students, and that we're planting these little seeds in students that, you know, even just a handful of them can go out and treat a handful of other patients with special healthcare needs, because even just these little drops of water in the bucket can add up to increase care for these marginalized populations. Because even just a little bit makes a difference. And just this one clinic in this one school can increase that access to care for this population. And I mean, for me, it's kind of a full circle moment what the CDRP program did for me. This research allowed me to come back. And now I'm mentoring these students and helping them kind of do the same thing. And I never thought that I'd be here talking to you guys today. And now it's the passion and I'm living my dream day in and day out. So it was a really great opportunity for me. And I'm just so grateful for what it allowed me to do and the opportunities that it gave me. So kind of already talked about that a little bit, but it created a network of opportunities and allowed funding and support to present at these conferences, which unfortunately due to COVID, I didn't get to do, but we're still allowing that opportunity now. And students that get to start research early, they can have that warm handoff like I had with the 4s who started the project for me. They gave me that warm handoff and I could pick it up as a 3 and then continue this as a 3 and a 4. And the earlier they can start it, the more longitudinal studies that they can have. And yeah, by continuing this CDRP program, it just allows for more funding, the more research opportunities. And, you know, these data allow us to quantify the difference that we're making and show in numbers, like that chart that I showed you, these numbers show us the difference that we're making in these students. And we have students that go out on their external rotations and they're treating these patients that come in with autism that their overseeing preceptors don't even feel comfortable seeing. And they're like, hey, I got this. I've already done 3 rotations, 3-week-long rotations in the special care clinic. And it's just truly inspiring to see the difference that we're making. And even if it's just that one patient that they're seeing on rotation, to me, that means that, we're making some impact with it. So there are the references. And thank you so much for your time today.
Thank you, Dr. Yineman. Let's give another round of applause to Dr. Coffey and Dr. Yineman. Excellent examples of our graduates from ATSU. Does anyone have any questions for either of our presenters? Speak now. If you think of one later, we're happy to pass those questions along to them. Thank you both again so much. We're very proud of you. Thank you.
Yes, thank you so much. Really enjoyed meeting you both. Enjoyed your story. Thank you. Thank you. We also have another cabinet member here today that didn't get introduced earlier. Sorry about that. I didn't see him. It's Dr. John Doherty. Dr. Doherty, could you give us your title and just say hello for us?
Hi, everybody. John Doherty. I'm a family practice sports medicine doctor, and I serve as the Chief Strategy Officer for ATSU.
We are so happy to have you here. Thank you.
Okay, I think we're scheduled for a 15-minute break, so it's probably good after lunch. Take a 15-minute break. We will come back, and Dr. Perry is going to moderate questions with Dr. Webster over Zoom. So we look forward to question and answer time with Dr. Webster. So see you in 15 minutes.
Okay, so thank you very much. We're going to continue on with our general session. We're on session 3. And again, we want to thank Dr. Webster Syriac for joining us here at AT Still. We're absolutely excited that she has taken the time out of her busy schedule to meet with us and share her story and some of the NIDCR initiatives. So we do have some questions, and we have taken some questions in advance, but we do have one that from Dr. Syriac. And this question is for Dr. Coffey. And it says, has Dr. Coffey considered research interactions in the context of a PBRN?
Hi, Dr. Syriac. Dr. Coffey has not considered that. No, I should. I think I want to get back involved, and it's just since ending residency and transitioning to a new city and all the fun things that comes along with that and board exams and everything else, I haven't been as involved as I should. But that's a good note and something that I will look into.
Thank you, Dr. Coffey. So our first question, Dr. Webster, did you have any feedback for Dr. Coffey?
Well, Dr. Coffey, I think we'll give you a break. I mean,
okay, so we're not hearing her if she's talking.
Can you hear me now? No? Can you hear me now?
Can you speak again for us?
Yep. Can you hear me now? No?
Maybe we can. Yep, we can hear you now. Thank you.
Okay. I said, Dr. Coffey, we'll just give you a break given all of those things that you've just gone through, plus having a new daughter last week. So there'll be time for you to rejoin us in research, and we look forward to it.
Awesome. Thank you. So our first question for her, and this first one, I think we've heard a little bit during her presentation. It was about her career path, and I think she shared that one with us. So we'll go ahead and skip that one. And so here's another question for you. And it says, is there an interest in NIDCR in developing an interprofessional integrated clinical model within clinical community health centers designed to address the integration of oral health, behavioral health, and primary care, primarily focused on oral health and disease states such as cardiovascular disease, diabetes among vulnerable and underserved patient population, and looking at some of the outcomes being designed to reduce A1C levels, reduce hypertension, improve periodontal health, and those UDS measures that we know the community health centers are so focused on.
So the short answer is yes. We need strong evidence-based research in the areas of integration with primary care and whole person health in vulnerable populations. We're not going to be able to get to oral health for all without it. And also in the areas of special care dentistry that we heard about earlier and other special populations. I did share with you that there is the ADAPT concept that was cleared last fall. Perfect opportunity for community engaged participatory research. We can bring in community healthcare centers, but also focus on interprofessional integrated clinical models. So short answer, yes. And there are multiple applications for this that NIDCR would be very interested in.
Thank you, Dr. Siriat. Next question is, NIDCR strategic priority number 3 includes an objective static for cross-disciplinary research that uses a community-based model for the implementation of oral health care prevention and treatment and engages researchers, clinicians, practitioners, public health officers, social workers, teachers, and other service providers. Question: how and where might the dental school clinics fit into this vision? What about clinical training sites such as FQHCs?
Yeah. So the dental clinics, including models like the one where you're bringing in medical professionals or physician's assistants, as well as the FQHCs, all fit squarely into that vision.
Awesome. Thank you. Thank you for that. Next question. What potential ways could AT still contribute to NIDCR's current strategic plan? I know you talked a little bit about that earlier. Do you see anything specific that you would like to highlight with us?
Well, again, we have those five areas. And I personally, given your focus on vulnerable populations, believe that in each of those strategic priorities and where they fit with ameliorating disparities, there's a place for AT still. There's a place for AT still in nurturing a diverse pathway or pipeline of students. There's a place for AT still in facilitating translation and implementation. There's a place for AT still as we work towards partnering in collaboration as you partner with community healthcare clinics and other professionals to move things forward. As we think about precision dentistry, it's going to take an understanding of the entire population, including those who are vulnerable and underserved. And so understanding the needs for those populations are going to help us get to precision dentistry. So I don't think that there's a place in that strategic priority list that there's not a place for AT still if there's an interest.
Absolutely. And thank you so much for that, Dr. Siriat. Next question. Historically, AT still has maintained a strong focus on teaching and education. Given that, what recommendations can you share when it comes to developing research, mentoring success in schools, programs with similar priorities?
Well, I think you're on good track given that you've already, you're integrating research into the curriculum, right? You're prioritizing it and really providing students the time and opportunity to explore and ask questions. I think that there will be, as we think about other institutions that are getting students involved in research, one place to look is the primed group. There'll be lessons learned that are coming out of that. And there are certainly opportunities for AT Still to interact with those different institutions, or as things move forward to perhaps get involved with Primed. Because the entire initiative is focused on getting students and faculty all involved with asking clinically oriented research questions.
Awesome. Thank you for that. So the next question, as a graduate health sciences university focused on preparing graduates to provide care to underserved populations, what type of institutional and/or interdisciplinary partnerships might best position AT Still to advance our research agenda and compete for NIDCR funds, mindful of NIDCR's portfolio, which, if any, more established institutions might be strong partners for AT Still?
So I'm going to turn that question around just a little bit, because it really comes down to, in the research, what question are you trying to ask or to answer, right? And then you need to think about what are the strengths that you're bringing to the table, right? And what are their strengths? I do think you have really have some pretty good partnerships in place right now. For example, your early detection network, right? Where AT Still is partnering with other universities to help move that forward. So in the cancer space. But I really believe that you need to take it based on what is the question you want to ask or answer, right? What are you bringing to the table in terms of your strengths to be able to answer the question? And how does that other potential partner help you to complement it with the strengths that they have? So I don't think that there's a specific place or institute that's the answer, or industry partner, but it really comes down to what you're trying to achieve and who can best help you get there. And as you come together and start to explore those partnerships, you can reach out to us, reach out to our program folks and share, here's what we're thinking about. You know, does this make sense? Is this aligned with where the Institute's going? But I do think you want to start, in my opinion, it really is not, you could have the best place in the world. And let's say you guys are the best place in the world at the underserved, right? And you put those two together, if you don't have a good solid question to ask, right? And you don't have resources really targeted at getting to that answer, it's not going to be a win. So I think it's starting with whatever the question is in the particular population, and then thinking about what the needs are, what you're bringing, what they can bring, and then how to move it forward.
Thank you for that. So the question and what our strengths are and what we bring to the table. Awesome. Thank you for that. So the next question we have, we understand that diversifying the research pathway is strategic priority 4. In the current NIDCR strategic plan, a key objective centers on developing new programs that enrich pathways of trainees from groups that are underrepresented in the oral health sciences workforce. Question, can you share more about what might be on the horizon in terms of new programs and how graduate health professions, schools like AT Still fit in that vision?
So I think that there's definitely a place for AT Still in the NIDCR vision. And we know, and from what I shared with you, you can see the things that are very important to NIH and to NIDCR are data, right? Are clinically applicable and community-based types of studies where we're reaching all the populations and making sure that we're working towards ameliorating those disparities. So I think training programs in those areas where you do have some significant strength, particularly in the underserved areas are important areas for training activities.
Awesome. Thank you for that. And some of these questions do overlap a bit, so we appreciate that. What future directions do you anticipate for NIDCR supported research as related to social determinants of health? And what about the public health within the realm of dental, oral, and craniofacial research?
Mhm. So, you know, NIDCR over the last couple of decades has made some significant investments in individual level interventions, right? So it's, well, can we teach the person or teach the parent about the importance of brushing, for example? There's been a lot of focus on individual level interventions. However, across these, we've never seen a significant decrease in the disease burden. So it really is incumbent upon us in the field to look upstream at social determinants, right? What are the other things that are critical, right? In terms of transportation and access and you name it, right? What that environment looks like. So the key is that this is a high priority for us. And in fact, in NIDCR, we're working on dental specific social determinants because right now, when it says, do you have access to healthcare? People are answering from a dental vantage point, right? And it's our hope, right now we're working on piloting this instrument and it'll become a resource for the field, AT Still and everybody else. So we're thinking hard about that because we are not going to be able to make the difference that we need to if we don't think hard about other structural barriers and other upstream determinants if we're going to really make a difference in terms of the disease burden. And again, this is not unlinked to public health. Public health in you know, what we do at the individual level is important. But what I shared with you at the very beginning was we've got the burden of the biggest the highest prevalence of communicable, non-communicable diseases in the whole world, right? And it's going to take prevention. And it's going to take us thinking a little bit differently about dentistry in the procedures that we do versus prevention and oral health, right? So public health is central to that, and to care and to health. So this is a critical future direction for NIDCR, as we're never going to be able to meet our mission of oral health for all without accounting for and thinking about public health, right? And thinking about how our science collectively can improve the oral health of all.
Thank you for that. And our last question that we received in advance is, what interprofessional or interdisciplinary research priorities exist within NIDCR? I know you hinted on that a little bit, but maybe you could share a little bit more for us.
Yeah.
Thank you.
So, you know, I'm going to go back to an earlier response, and that is it really depends on what question's being asked, right? What the team that needs to come together to answer that question is really going to depend on who can help answer the question. And in the context of the community, who are the other players, right? As I'm, you know, thinking about people who are 6 years old, you know, other partners that might be critical might be the pediatrician or the teacher, right? It depends on what question the question is being asked. If I'm asking something that's more biochemical, you know, we'll bring in different partners. But it really is, I think, for the investigator, you, to think about who else do I need at the table to help me answer this question. Okay. And I'm not trying to throw off not answer the question, but that is it. That is it. And the other thing to remember is, you know, please take a look at our website, and I've had a chance to share with you some of our major priorities. But you are in the field, you see the problems, you know what the challenges are, and you can ask and initiate the question. So, and in fact, the majority of our funding goes to investigator-initiated research, right? Where the investigator has said, oh, I've noticed XYZ in my Downs population. I'd like to know how best to utilize Botox in their treatment. Oh no, that was cerebral palsy. Sorry about that. Trying to go to one of your earlier examples. But bottom line is you can help define that. Okay. It is what question are you asking that might be relevant, those answers that could be relevant to help other populations across the United States and the globe. Okay. So you can, when you look at our strategic plan, that you can see is pretty agnostic, right? I mean, we went through some kind of big picture things that we need to do, right? TMD, oral cancer, caries and perio, preventable, right? I mean, these are things that are high on the radar because they're high prevalence, right? That those people are not being attended to because they don't have access or because people don't believe they can treat them, special needs population, right? So all of these things are high priority. The key is that you make that case in your application. You share why this is an important and why it will make a difference, not only to your population, but to others.
Absolutely. And thank you so much for that, Dr. Syriac. That concludes our questions that we have received in advance, and we're prepared to take questions from the floor. If you can state your name.
Yes, good morning. This is Stephanie McGrew. I've met you a few times at the National Dental Association conference. So it's good to see you again.
And good to see you.
We often are advised that ATSU is not competitive for grants that appear to match what we do with our Dreamline Pathways program. Yet you've stated specifically several times today that our program could be funded. So what exactly are we missing? And then what specifics do we need in order to make sure our program fits to get funding?
Mm-hmm. So the mechanism is called SEPA. Okay. SEPA is the name of the mechanism that would fit the Dreamline pathway because that entire mechanism is focused on engaging young people and giving them exposure to science and to healthcare fields. Okay. And I'm not sure who you may have engaged with who said that what you were doing wasn't aligned with what we're doing in NIH, but happy to, I mean, I do think Dr. Brown, you can reach out to her or to me and we can talk with you directly about that mechanism.
Perfect, thank you.
You're welcome.
Thank you, Dr. Syriac. Thank you, Stephanie. Is there another question? Okay. Okay, well, we have one. If you can state your name for us, please.
Hi, Dr. Webster. This is Julie Bauer-Cook. I just have a question. Can you share more? I'm thinking when you were talking about social determinants of health and looking upstream, what, if at all, interest or activity does NIDCR have when it comes to research projects related to oral health literacy and access to oral health education materials? Thank you.
Certainly. Yes, that is also a high priority. If you can take a look at the portfolio for our behavioral group, and perhaps our prevention group, because oral health literacy is critical to prevention and to moving things forward. So there's definitely an appetite for research in that space.
Awesome. Thank you for that. Okay. Are there any other questions?